Hi, it's the Chappiness guy. Welcome to today's episode of Vestibular Talks. We have a very special guest in the house today. She's an amazing woman. Her name is Sarah. She's a physiotherapist. She's a coach, and she educates those with dizziness and associated anxiety and stress in order to restore and maintain active, meaningful lives. You can also find her doing telehealth conferences, and she's also on the Vita website as well. So she's here to share with us some of her experience and knowledge, trying to guide us on how we can regain our lives back after we've been dealing with dizziness. So stay tuned. Remember to like, share, and subscribe. Find your happiness, guys. All right, we're recording. Good morning, Sarah.
Good morning. How are
How are
you?
you today?
I'm doing well this morning. Yeah.
Good. Yeah, thank you for being part of this episode of Vestibular Talks. It means a lot, so I appreciate it. Thank you very much.
Sure. My pleasure. Thank you for asking.
All right, Sarah. So you mind telling us a little bit about you, what you do, what's your profession?
Mhm. I'm Sarah Conover. I'm a physical therapist. I'm a vestibular rehab specialist. Um, I happen to be a physical therapist. There are OTs that are vestibular therapists as well. I have been a physical therapist for going on 33 years. Back when I got my PT degree, um, we learned, we might have had, oh, by the way, there's these, balance centers in the ears, and they help you out with your balance. And we learned the anatomy of the inner ear and the nervous system and all of that. But really, the body of knowledge has grown so much in 30 years, and we are able to treat people with vestibular disorders so much more thoroughly and better that way. So I started out. Do you want to know kind of my background in PT?
Please, yes, of course, yes.
So I started out in my first job out of PT school was in the neurological intensive care unit in Norfolk, Virginia, in Norfolk General Hospital. And so I spent the day in the intensive care unit seeing folks who are very sick with new head injuries, new strokes, and new spinal cord injuries in the ICU. And it's huge hospital. So the I think it was 8 or 10 beds were dedicated to neurological problems. Then we came back. I grew up in Indiana, so we came back to Ohio then and settled in Ohio. And I continued neuro rehab, but in a rehab setting. And I've done since then rehab, neuro rehab, acute rehab, outpatient neuro rehab. And then in the early 90s, I took my first vestibular course and got super enthused about the ear and things. And so at that time, then I just had all my colleagues just send their dizzy patients over to me to see, they might have been seeing them for a back problem, and they lie them down and they spin, and okay, you need to go see Sarah. And I would do some of the things that I learned, and then as I've gotten more and more involved in it, I've specialized more and more. And now my practice, I practice in a small outpatient practice in Ohio, and it's about 95% vestibular, my practice. And then I've also just recently kind of gone out on my own to do some telehealth physical therapy as well. So I do that
Awesome.
for vestibular.
Yeah. Thank you for sharing. Sarah, so I didn't know that. So you can kind of like broaden the studies when you're a PT, physiotherapist, to go into different directions, right? So you decided to go into the vestibular world to learn more about it. What other offshoots of physiotherapy are there? Like you can specialize in different things. I didn't know that.
In physical therapy? Sure.
Yeah.
Yeah. Oh, absolutely. I mean, you can be a generalist, and have a lot of go more shallow into a lot of different areas, but there are a lot of different. In fact, there's board certification in different specialties like neurological, orthopedics, sports medicine, pediatrics, cardiopulmonary, different, a lot of different specialties.
Yeah.
Folks, there's some therapists who, specialize in throwing injuries, or those things like that. Yeah, it runs the gamut. Mm-hmm.
Okay, nice.
Yeah.
When I found you on Instagram, I found you under the name the DC Coach.
Mm-hmm.
So tell us a little bit about the DC Coach. What inspired the name, and how do people respond to it?
Well, I chose the name because one of my favorite parts of being a vestibular physical therapist is like that coaching aspect. So I love to teach, to educate my patients. It is, it's really great to see people who can learn how to be an active part of their, in fact, the main part of their healing journey. So just like an athlete, and his or her coach, the coach knows kind of how to get from point A to point B, knows what the athlete's strengths and weaknesses are, what they really have to go hard at, and what they can accentuate, and makes a plan. But it's the athlete that just puts in the work and does it. But the coach encourages and instructs, pushes a little bit, maybe scolds a little bit, gently, lovingly, and then also reroutes. Okay, this didn't work. Let's try this. Advocates. So there's a big part of that most physical therapists do, that coaching kind of work and advocacy kind of work as well. That resonates with me. I love that part of my interaction with people. So there it is.
Okay. And Sarah, so as you know, there are many different types of vestibular conditions or disorders. BPPV, which is the one with the crystals coming loose, PPPD, vestibular migraines, vestibular neuritis, many different, I don't want to say illnesses, but yes, conditions or disorders. What would be the most common one that you often treat? Would it probably be fair to say that is BPPV, the one with the crystals?
It used to be. So BPPV is very common. And probably I would say 10, 15 years ago, that was a lot of what I treated. But a lot more physical therapists as well as physicians know how to reposition the crystals. So it's one of the easiest, fastest things to treat. And it's really wonderful when you can help somebody who's really spinning like crazy feel better in such a fast way. So BPPV, if anyone doesn't know, it's when these crystals, calcium carbonate crystals, called otoconia, get out of place in the inner ear. So they belong in the little sac pouchy parts of the inner ear, and then they get loose and they go into one of the semicircular canals and float through the fluids and make your brain think you're spinning because they stimulate the nerve ending a little bit differently on that ear. So so many other kind of providers are learning how to do that maneuver that I don't see them as much. Plus my practice is about, like I said, about 95% vestibular. So I'm getting a lot more of the conditions that are maybe they saw someone else and it wasn't, they tried the Epley maneuver and it didn't work, and they went here and here and here, and they got on YouTube and they tried this and it didn't work, and so then they end up in my office. Yes, I do see probably half dozen new BPPV a month or so, but not the percentage that I used to.
So what you're seeing more, from what I'm understanding, is more chronic cases. People that have tried the Ipley maneuver or different other maneuvers didn't resolve their dizziness, so they come to you to see how they can maybe adapt or hopefully resolve the dizziness that they are experiencing. Do you, at that point, when you see them that they are more chronically dizzy, is there another test or referral that you send them to make sure that it's not maybe a stroke or a concussion or signs of MS or signs of something like that? Or what kind of procedure do you do?
Yeah, it depends on where they come from, where they're referring from. So I live in Ohio, practice in Ohio, and we have direct access. So I can see someone legally who comes without seeing a physician prior to seeing me. And I do get a fair number of folks who see me through direct access. Word of mouth, you fixed my Aunt Lucy and she loved you. So, and I'm dizzy. And as you know, one dizzy condition is not like the other condition. Those folks, absolutely, if there's any red flags, I do a neuro screen, and if there's any red flags, especially neurologically, and they've not been to a neurologist, or there's no known condition that would explain those signs, I refer them on to their primary care doctor or straight to a neurologist, depending on the situation. If it's something if it's direct access and something I'm pretty confident, if it's BPPV, I can identify that, pretty easily. If it is like an acute neuritis, there are really good signs that tell us that it's that. And if in the absence of some of those neurological red flags, I would go ahead and treat them, start them on a program and just monitor them. And if they're not progressing or if something doesn't look quite like it's expected, then of course refer them on. More and more I'm noticing, at least with my ENTs that are referring, that they're holding off on some of the vestibular testing. They'll do an audiogram, but some of the vestibular testing, they'll hold off and see kind of what can we hone in on, and what are the best, was the best testing protocol for those patients. So it really depends on the situation. Do they need immediate consult with a physician because of red flags? Do we want to treat it and kind of see, is it looking like what it's expected to look like in the progression, and then refer? Or is it something, hey, you've been to your primary care doctor recently, you're in good health, it's, easy to treat, let's just go ahead and progress with the treatment.
Okay. Regarding treatment, I know, like you mentioned, every DC case is unique. So regarding treatment, what's the rough average that people need to stick to a therapy and treatment in order to see some improvements?
The average time, is that?
Yeah, length of time, yes.
Right. Okay. That varies vastly. So someone with just BPPV and no like concussion or other, coexisting condition, just a couple treatments, if, many times just one. And so that's like that extreme versus someone very chronic. And so I kind of look at coexisting conditions to set my expectations for the treatment, the length, the duration of treatment. If someone with just straightforward like vestibular neuritis, acute vestibular neuritis, and they're otherwise healthy, there should be no reason why that person can't get to pretty much full compensation within 4 weeks, 6 weeks. A lot depends on the issue that we have no control over, and that is what's actually going on in the ear. So we are kind of skirting the issue or the question a little bit, going off on a tangent, but I'll get back to it. But how I describe what we do as vestibular rehab specialists is like a jet airplane, where the pilot is the brain and the ears are the engines. And the pilot is used to flying the plane with all the engines going, and if there's an experienced pilot, doesn't have to think a whole lot about it. You got a pretty smooth ride. You got one of those engines that's misbehaving. The pilot can fly the plane, but the ride's going to be bumpy at the start until the pilot figures out how to switch around, how to do the controlling. I'm not a pilot, so fly it differently. So we teach the pilot how to fly the plane with this, engine that's not working real great. And so that's what the basis of vestibular rehab is. It's brain work. We're not engine mechanics. We don't go in there and fix the ear. So if someone has underlying anxiety, like an anxiety disorder, or is prone to anxiety, or things like, even depression and a little bit as well, that's going to take longer to treat. If they've had like prior occurrences of the condition, that's going to take a little bit longer. And basically, my job is to get them to their full potential, and wherever that is, stabilized there, and on a good maintenance program with activities, exercises, and lifestyle changes.
Okay. I love the fact that you said the word anxiety, because many people that were experiencing vestibular symptoms in the past, when the vestibular system wasn't too mainstream, which still isn't, but at least is more known now, many people that were going to the doctor saying, hey, I'm feeling like dizzy, or I'm feeling like something is off, the doctor would say, oh, you're just anxious. Here, take an antidepressant, or just brush it off, like off your shoulders. It's just anxiety. Now more people are being diagnosed with, hey, you actually have a vestibular disorder, which is good, but it's not, because I've seen many more younger people being diagnosed with Meniere's disease, which Meniere's disease is something that often affects people in their 40s, 50s, 60s. But I'm seeing people in their 20s, 30s giving the diagnosis of, no, it's Meniere's right away. It could be Meniere's, but they don't even do a hearing test to confirm whether it is Meniere's or not. It could be vestibular migraines. It could be vestibular neuritis. It could be PPPD. It could be anything else. But now they don't slap them with the whole anxiety level. Now it's like, hey, you got Meniere's. So how do you think we can kind of like educate people properly to tell the difference between these conditions, because they are so similar, like the symptoms are so closely related, and to understand that when someone is anxious, it could truly be anxiety, or it could be related to the vestibular system as well.
Yeah. So I'm going to separate that out into kind of two questions. One is the anxiety versus dizziness, kind of. So anxiety causes its own little version of dizziness. Its own, and sometimes it feels a lot like the sort of fuzzy-headed dizziness that you get from a vestibular disorder. And a lot of times what happens, at least in my experience, is you're dizzy. You actually have an ear thing that makes you dizzy. And then the anxiety kicks in and makes you dizzier, because it adds its little variety of dizziness. Yeah. And then that doesn't help the ear either, because you're on guard, and you're you're in a more exacerbated kind of condition. So that doesn't help the ear to heal because it is stress. You're stressed, and it's a little bit of a downward spiral. So if that's why I do a ton of education, because I believe if I can lower that anxiety, I'm not a mental health professional, but I can with education and with relaxation techniques and things to quiet down the autonomic nervous system, that fight flight response that so many people it's elevated anyway. There's, I use vasovagal, I'm sorry, not polyvagal techniques to activate the ventral branch of the vagus nerve, to get into that. You want more of that rest and digest, that parasympathetic. So if it comes out of mental health, the polyvagal theory, and I use some of those exercises to quiet people down a little bit somatically, their body. So if we can get that, plus knowing that you're going to be okay, will help you kind of calm down a little bit, and then the healing can take place a little better. So it's really hard to tease out what is the vestibular dizziness and what is the anxiety dizziness. So just working on them both to just quiet them both down. Now, the second part of that question was Meniere's versus vestibular migraine, I think. It's not my place to diagnose either of those. I know a lot about them and the diagnostic criteria for them. And I do, my eyebrows kind of raise sometimes when someone comes. It's not my role to change that diagnosis, to educate the doctor on a better diagnosis. I actually find that that's improving a lot. If someone comes to me with Meniere's disease, I always ask, when were you diagnosed and who diagnosed you? Because I find that folks that were diagnosed years ago, I question that a little bit more because we didn't know as much years ago about it. But recently, by a specialist, I take it a little more seriously. Part of my role is to educate the patient on what questions to ask. When you return to your doctor, see about this or ask about this. And then, in my communication, especially my colleagues who I work closely with, that are physicians, I always give my impression, in a report. If a physician has referred a patient, I get, well, even if they don't, when I do my initial evaluation, I give my impression that the person's picture, their symptoms based on the subjective and the objective. My impression is that their picture looks very, very similar to, or is consistent with this or that. And but I don't put those two diagnoses. I don't put those diagnoses on the patient. I do other diagnoses, which I'm qualified to do, but not those.
Okay. Sarah, I've seen different physiotherapists that are using newer technology to aid them finding balance. So the VR glasses, like virtual reality, other ones have this weird chair that spins people in all sorts of directions. Other ones have these goggles that kind of like show if you have any if your eyes are vibrating. Yeah. Thank you. And different technology aids. How do you feel about those things? Do you think that they do help, or that they are more confusing, or do you use any of them? Like, what do you think about it?
Yeah, I work in a very small private practice, and so it's very low budget. And so we don't have a computerized balance platform. I did prior, so I've been here maybe 6 years. So prior to where I am now, I used a computerized balance platform for assessment and training. I personally, I have to have my goggles though for my that's really the only piece of, aside from like standard exercise equipment, treadmills and stuff, that's the only piece of vestibular equipment that I pretty much have to have if I'm in the clinic, because it does something that you can't get at any other way, and that is what the eyes are doing, how they're behaving in the dark.
Yeah.
So that's what. So if you got like an acute onset of neuritis or something, you would have that nystagmus for a while, a day or two, maybe just a few hours, depending on how quickly you're resolving, in the room light. But very quickly, your system, our systems are created to be helpful to ourselves, and they quickly
They adapt very quickly.
Yeah. And it's just amazing. The human body is just amazing creation. And so after a little while, you have to, in the room light, you suppress that nystagmus more. Okay. Sometimes you can bring it out with the tracking, and especially quickly, and especially the elderly population. But then when we put the goggles on, you can't fixate on anything. So that nystagmus it comes out. It's called, with visual fixation removed, blocked. And that can tell us a lot about what is going on. Are there more peripheral signs or more central signs? The other equipment, like the posturography equipment, is very helpful for determining like which sensory system is off, and how the sensory systems are playing together. What is the impact of the sensory systems on balance? Some of the other technology that's used is like a computerized dynamic visual acuity test. So how well can you stabilize your vision while you're moving your head? I can do that. I don't have one of those fancy pieces of equipment, but I do that by moving the person's head and having them try to read an eye chart. So everything else, and then I do the canalith repositioning treatments on a treatment table. Occasionally I'll have to do something a little bit tricky if the person has a really tight neck, or precautions for their back or something, and we'll have to modify it a little bit.
All right. Sarah, I've seen a few different specialists when my whole vestibular system went a little bit out of whack, and some of them were really pro medication. They're like, hey, the medication is going to help you, plus you gotta go see a vestibular physiotherapist to get you moving the way you need to start moving. Other specialists were like, no, go see the physiotherapist, the vestibular physiotherapist, but do not take medication due to ototoxicity, because they believe that certain medications could poison or dormant the vestibular system more, which then it will delay healing process, because if you go to a physiotherapist to do the VRT therapies, the vestibular rehabilitation therapy, you wouldn't absorb all the information properly because your system is dormant type of thing. How do you feel about ototoxicity, and whether medications do help or they kind of like inhibit getting better?
Yeah. So you're talking about like the meclizine and Introvert.
And even the they prescribe these antidepressants for vestibular migraines that suppress your vestibular system.
Right. They're vestibular suppressants. And that's different than like an ototoxic medication like chemotherapy or like a vancomycin or something, gentamicin, which is toxic to the inner ear. But vestibular suppressants just dial down that vestibular system, so it's not as responsive to rehab, and we know that. And how my opinion is that there is a time and a place for quieting down that vestibular system. If someone cannot stop vomiting, that can be dangerous, and we need to quiet that system down. So I don't prescribe those. I educate the person. One of the real common things that I see is that not so much ENTs, but many primary care physicians or emergency rooms will prescribe that, like meclizine or Zofran or something. And they'll say on the prescription, 3 times as needed, 3 times a day as needed. So the as needed, the patient interprets that sometimes as, well, I'm still dizzy, I must need it, and I must take it 3 times a day. So I do a lot of education about what that means. That what does as needed mean? and then
sorry to interrupt. It's very interesting because that's specifically my case. I don't like to get too personal about my own story, but I got prescribed flunaricin for the vestibular migraines to kind of like tone them down. But a different doctor said, no, if you're continuing to be dizzy, also take meclizine on top of the flunaricin. And the bottle says the exact same thing, 3 times a day as needed. And but he didn't specify, no, only when your dizziness is really strong. So at first I assumed, okay, I just gotta start popping these 3 times a day every day until I run out of them. But then I did some research online, and it says no, like it's only when you really, really feel that the dizziness is like out of control, out of whack. So this will decrease it a little bit. That's how I take it now. If I feel I'm having a day where everything is starting to spin more and more, then I take one, and it doesn't even make the dizziness go away, but it decreases it to a point where I'm more stable again. And I'm like, okay, I don't need one anymore for now. I'm okay. So that's why when you said that, I was like, that resonates with my own story so much.
Yeah, it's pretty common. Yeah, and again, I do not. I don't take people off medication unless I've been specifically asked by the physician to work with that person on, and they want them. I educate the person on what is actually doing. It doesn't cure the dizziness at all, and some people have not even been told that. So there's, it's like, and the way I describe it is, if you tore your rotator cuff, if you had a big tear in your muscle and your shoulder, and you were hurting from it, and you took some Tylenol, that Tylenol doesn't fix the tear at all. Okay, it just helps you maybe get through some of the pain that is associated with that. So it's the same way with the meclizine. It doesn't. I mean, it's not an exact analogy, but people kind of get it. It doesn't cure the dizziness.
Yeah. So will you recommend the meclizine? People take it enough short term, but focus more on the physical aspect of the vestibular physiotherapy rather than just completely relying on the pill to decrease the dizziness, because eventually at some point they need to get used to adapting. And I believe high expectations of like, oh, with the many people online, they said, oh, VRT didn't help me because they are still dizzy. And I'm like, yes, because VRT is not a cure to say you'll never be dizzy again. It's a way to help you adapt to your dizziness. So I think people need to be more realistic with their expectations that hopefully we all get cured at some point. But if not, we need to learn how to move again and how to tackle life again with this dizziness.
Yes. Again, I do not blatantly say stop the medication. I will educate and I will say, you may want to think about when, what, and try it out maybe. Are you really dizzy? Or do you just, dizzier or whatever, try it without. So a lot of times people will come back and say, I tried not taking it and it really is not, it didn't make much difference whether I took it or not. I realized it wasn't really helping me much. There's a lot psychologically about taking a pill as well. If you think it's doing something, then, it's the placebo effect, right? So, so there's that overlay on it too. And so when you educate people on what it's really doing in your system, they can make a more educated decision about whether they're going to put that pill in their mouth or not. And also give them different strategies to, like anxiety reduction and all of that can really help reduce and get through those periods of time where that dizziness, it seems a little more extreme.
Yeah. Sarah, where can people find you?
Yeah, so I am on, I'm not super consistent on Instagram, but I am, I'm the Dizzy underscore coach on Instagram, and www.dizzycoach.com. I also am listed on the Vita website. I'm so my telehealth practice, as well as my private practice. I do an in-person support, a vestibular support group. I facilitate that once a month, and I've done that for maybe 6 years or so. And then I'm also going to start doing an online support group as well through Vita. You can, if you want to email me, I'd be happy to have correspondence email. You can email me at sarahpt@dizzycoach.com. So, yeah.
Awesome. If you being the dizzy coach, if you had to say one encouraging word to a dizzy patient, what would that be?
Oh, wow. One word or like a string of words?
Like a sentence. Yeah.
Okay, one thought. Get people around you who are, get a professional provider that knows what they're doing, that can support you through if you don't have someone walking that journey with you yet. And get people around you who can be very positive support. I firmly believe that where your thoughts are really affect your whole being, and and the neuroscience proves that we can change how we feel and our feelings emotionally, as well as our body feelings, by changing our thoughts and being around positive people who have practiced gratitude and positivity. Does a whole lot more than surrounding yourself with folks that are in that sort of negative and focused on their symptoms. So it's great to have fellow people who are going through that journey, along, can relate. But just what if you're in a support group, just watch it and make sure it has the right tone, and that's a uplifting and not focusing on. The more you focus on the what you can't do and what you don't have, the more power your brain has in that area. The more you focus on what you can and have and where you're going, and gratitude, really those thoughts, your brain actually rewires. The physiology of the nervous system changes with practice in your thoughts, and it's a huge thing for people with any kind of chronic issue, including vestibular.
Mindset is key for sure.
Mm-hmm.
Awesome, Sarah. No, thank you very much. Really appreciate you taking the time to be with me and to talk to all of us about your experience. And yeah, I hope that we can do this again sometime in the future to talk more about how the DC coach is changing the world, finding balance.
All right. Well, thank you so much. This has been lovely. Thank you.
All right.
Appreciate it.
Bye, Sarah. Thank you.
All right. Bye-bye.